Okay. Just a real heads up. I'm calling from, I'm on COVID isolation. So luckily I can't give it to you over tele, but if my pup pops in the background, I'm in a hotel room isolating with him. Really great to be here. It's actually really heartening to see so many familiar faces. We've all been working really hard to support young people. I have, oh, this is going, let's go back. I have with me 3 other Hazel Health team members, but for the sake of time, I'm just going to ask, I'm going to introduce myself and ask Andrew Post to introduce himself, but the rest of us may jump in for some questions. So for everybody that doesn't know me, I'm Michael Fu. I am a Stanford trained physician, and my focus has been on pediatric mental health from the very beginning of my career. I also am a former middle school teacher from Chicago, and so dealing with trauma and mental health really started from understanding, sorry, that's my pup, understanding what really is relevant for young people, especially marginalized populations, low-income families. It has been a pleasure in the last couple of phases of my career trajectory to work in a digital health space, applying how do we bring in the service component as well as the technology component to actually engage and provide meaningful services. So I will leave it at that for now. I'll ask Andrew to introduce himself as well before we jump in.
Absolutely. Thank you so much for having us today. Andrew Post, I'm the Chief Innovation Officer for Hazel Health. My background is actually largely in schools, at least for the first half of my career, as a teacher, assistant principal, and principal in Miami-Dade County. I was then the assistant superintendent in Duval County in Jacksonville, Florida, and spent the 4 years prior to coming to Hazel at a company called Invo Healthcare, where I both built the first mental health platform infused with behavior analysis as a new way to address the effects of childhood trauma, and also built the first value-based care model contract between Invo Healthcare and Magellan for applied behavior analysis for children with an autism diagnosis. And really have enjoyed watching the reception of school districts and health plans as Hazel has really grown quickly to a number of states, including the first complete state of coverage in Hawaii, which will launch next month.
Thanks, Andrew. Before I dive into our company, I wanted to share, you can see some statistics about us on the side. We're at 225 employees, rapidly growing. One of my main drivers for joining Hazel was the mission orientation. So we are a venture-backed and impact investor-backed company, but we are very mission-oriented. So Hazel was founded on the belief that we need to provide access to all children, regardless of income, insurance type. And so that has been the commitment from the very beginning. Our team, from everybody from providers to our executive team, overall, we have about 55% of those identifying as people of color, self-identifying. 70% of our clinicians have community-based care. So we really believe in bringing that community focus to everything that we do. On the mental health side specifically, our team is actually skewing more towards 60-70% self-identifying as BIPOC. And that is very inherent to like the work that we do day in and day out. In terms of Hazel, we are actually the nation's leader in terms of school-based telehealth. We started over 6 years ago. Before COVID made telehealth a huge thing, our priority was, let's focus on pediatrics. Let's focus on telehealth-based school care. Let's make access available to all students. And so we developed an on-demand urgent care practice at the very beginning of our work. And then over time, we discovered, especially during COVID, schools really reaching out, families really reaching out, parents reaching out for additional help with mental health support. So we took our time to understand, how do we design a service that makes sense in our model, but also makes sense for the students and families. And we co-developed this with school district partnerships, as well as with health plan partnerships on the Medicaid side to figure out how to build a sustainable model. For the purpose of this presentation, we're just going to focus in on our mental health service and business. At scale, we have over 2 million students across the country that we're partnered with. I do want to highlight that from the very beginning, delivering care in schools, we know is very hard. Everything from the sales process to the operations of it, technology as well. And what we've learned is that the combination of excellence in service as well as technology is what leads to that trust and engagement. So we have 85% family opt-in rate for our services. And we will go into how students and families get referred to us, but I think it's a testament to being able to unlock with school partnership, getting families to buy into medical care, which we all know is hard for many families because there has been marginalization by the healthcare system. Our services are available both at school and at home. We provide technology to the schools to enable this. We provide training to the schools to enable this. And as well, our services are available again for the students and families, even if they're outside of the school during school hours. So I think we all are coming to understand that, and a lot of us knew this already. Schools already are the front line of mental health, especially for young people. Whether it's a school-based health center or a teen van, those are sites of care because that's where students are. And as a former teacher, you really understand the social emotional concerns of families. So the reality is, even before COVID, that's where this was happening primarily. We also know that families right now, and superintendents, especially in school systems, they are investing in the mental health care of their students, given everything going on. Um, we also know that there's a huge equity and access gap, right? Just because you have providers does not mean that people will use those providers. And also, just because you need services doesn't mean you will get them. Historically, through the country, I think anywhere from only 2 to 4% of students who deserve care, who are on receiving public services, for instance, are actually getting them. So that is another fact that we want to counteract here. Although schools are investing in these solutions, it's actually a very difficult battle. So we've included here a quote, for instance, from one of the largest school districts in the country that we're partnered with. It's really awesome to see school districts and governments sort of support us in investing in more providers for schools. The hiring environment is just hard. Getting people to basically commit to place-based services, the reality of school-based burnout, but also just like the competitiveness of the market makes it hard for schools to continue to staff. The threat there, I think, is that if we don't invest in figuring out how to bring more providers dedicated to school-based services, we will lose them, right? And entire generations of students will grow up without that access. So there is a commitment, and for Hazel's end, we are committed to helping sustain and scale and making sure there are school-based providers going into the future. In terms of our model, so we are all telehealth based. On the mental health side of things, we have a couple different ways different services we stand up. So we provide a multiple entry point, no wrong doorway access into care. So we have our physical health service, the urgent care on demand, in which oftentimes our MDs, PAs, NPs identify behavioral health concerns that they can then flag and make internal referrals for. We also have school referrers. They are our prime referral sources for our mental health service. We do upfront training, a lot of hand-holding, and we co-develop workflows so that we don't force them to take our workflow. Instead, we adapt to district workflows. As a preview of this, some districts have their own designated clinical team and their own workflows. Some do not. It really varies. So we work hand in hand to make sure that it's customized to whatever works best for that school district. We also do a lot of work with the school district in terms of data integration. So on our platform, we're able to actually take in the entire student information system in terms of name of students, parent contact information. We get this ahead of time before even launching a school. So that is all set up with us. Our model for therapy is we provide a short-term teletherapy model. We hire and train all of our clinicians. So we look for those with school-based background, with a passion for serving the communities that we serve, with significant experience working with parents and families. We take a short-term therapy approach. So think of it as a bridge service of sorts. Using evidence-based treatment, we deliver therapy. We're able to do intake appointments as well as ongoing therapy appointments, again, at school and at home, all through our telehealth platform. We also, I think, one of the most important parts of what we do is the care navigation and support. So even though I'm an MD, it's really hard to navigate the medical system in terms of seeking mental health care. Personally, I've had to wait over 2 months to go through my insurance to get mental health care before. And so from day one, when somebody gets referred to us, we call them family resource managers. They are our case managers. A lot of them come from medical case management, mental health case management. They actually provide a lot of the outreach to help parents get consented, opted into the program, but also give them a preview of what's going to happen. A lot of parents just don't understand, am I overcommitting? What happens next? So we provide that guidance and support throughout our process. In addition to getting them to that intake visit to successfully get seen, we also help them with other resources. So one thing we have found is, as Hazel, as we are in the schools, we are seeing students probably more so than your pediatrician, right, or your adolescent health doctor. We uncover a lot of gaps in care. We uncover a lot of cases where students are not plugged into the insurance system, not seeing their PCP. So we do play a role in helping them get back into that ecosystem, back plugged in, so that we can get them other services that they need. Our case management team also does follow-up care for up to 6 months after a program discharge. So we have a commitment to the schools and the families to make sure that, for instance, if we need to refer you for specialty care, we're there to support you to make sure we're getting you there. So that is the comprehensive package. Everybody that goes through our services gets all of these. We also have a crisis consultation service. This is specifically for helping school staff who have to make these very difficult decisions of, do I send a kid to the ED? Do I send them to the hospital? What we've heard from school staff is that This has gotten increasingly more common, unfortunately. They themselves are more burning out, and it's just a burdensome decision to make. And not everybody is fully clinically trained. And so this is a way for us to basically on demand have a second opinion and help guide in terms of risk assessment. Can we avoid the ED here? Can we go into a lower level of service? It's also a way for us to help our physical health providers if crisis ever happens in one of our physical health visits. I do want to touch a little bit on what it means to provide school-based care from our perspective. We are going into other people's ecosystems and homes. And so for us, our approach is we want to integrate, and we do integrate with school workflows and existing community resources, because schools for decades have been figuring out how to do this on their own to the best that they can. So this is an example from Hawaii. It's not fully our Hawaii example, but I wanted to show you exactly what it might look like in different places. So for us, we integrate with the school counseling staff. So they may have their own escalation pathways, but we train them to help triage and identify what's the best cases for Hazel to take on. So we build referral systems that way through our platform, and we can get it that way. We also can get referrals from in Hawaii, there's something called Hawaii Keiki, which is school-based healthcare support systems around the school. So although they are themselves a referral source for counselors, for instance, sometimes they are at capacity or they need additional help, in which case they can also refer to us as well. Parents are one of our highest quality referral sources. A lot of folks are struggling even to understand, where do I start? What's the severity level of my student? So we have a lot of parent self-referrals as well. I'm really proud also of our ability to think about minor self-consent. This is a really tricky subject with school-based healthcare, but many states have minor consent laws where above a certain age, for instance, in California, it's 12, you yourself have control of your mental health care as an outpatient mental health service and can consent for that. So we actually started doing this in Washington State and Colorado State to understand how we best serve adolescents for this pathway. It's one that we have to work with health plans for, as well as school districts, because we have to be very careful of privacy and consent issues. But we already have that started, and it's something that we want to keep expanding. I do want to touch a little bit on what happens after. So right now we focus on mild to moderate teletherapy. Sometimes you might have a psychiatry need, for instance. Well, we tap into the local ecosystem by focusing on working with health plans and case management teams, as well as the resources that the school has galvanized around them to figure out where locally can we also direct that family to basically make a warm handoff. So that goes everything from ongoing care for long-term therapy to specialty care to plugging them back into the medical system as well. So outcomes, what have we been doing? We have 2 million students nationwide that we are partnered with. We work with affluent and low-income districts, rural and urban, really large and really small. We're proud to say we're getting kids care less than 2 weeks. We also outreach to families as soon as we get a referral within a day, typically. We are seeing really good trends in terms of referral rates from districts. So 5 to 8% in year one of launch. And these are at large districts as well. We're getting 5 to 8% of students referred to us. I think we all know about incidence rates and prevalence of mental health among adolescents. And so we will see that reach, that 20% that we typically talk about years 2 to 3. Typically, we do have completion of about 6 sessions. So we have an intake, and 6 sessions is typically what we frame around. And then we are seeing that we are getting kids in front of us 2 years earlier than the national average of diagnosis. So I think that's around age like 14 right now. We're getting them around age 12. Going to go a little faster. Parents, it has been outstanding in terms of reception by parents. You can see our Net Promoter Score. For us, we also have to make sure that this is convenient for the parents. So saving them hours of work, basically coming to pick up a student, leaving work, that is huge for them. But also being able to build the trust so that they're not on a wait list for 3 months or a year sometimes, but also that they're equipped and trusting of the services that we provide. This is something that we are very proud of. I do want to briefly say that this was in partnership with Hope Lab. We're all adults in this room, and how do you design a service that works for kids and teens? This is early works of an early framework that we use to guide our product development process, understanding that teens go on a journey. Not everybody's ready to accept therapy at the very beginning when you refer them. So we build our product and service backwards to understand how do we get them to that point. Our current footprint. So we have a significant footprint. This is just our mental health. As you can see, we are comfortable working with very large districts, as large as 315,000 students. We also have small districts, and we equally prioritize them. So some of our districts are rural and less than 5,000 students. This is just to show you that we are able to quickly scale, quickly grow, and also implement state strategies. I will actually now turn it over to Andrew to talk more about our Hawaii case study as a specific example.
Yeah, thank you so much, Michael. And so I will keep it brief. But We're really excited about this opportunity for a number of reasons, not the least of which is this is the first full statewide solution. And while Hawaii is a single district state, the reality is the navigation, the coordination with the health plans, and particularly the 5 MCOs that also in some cases serve commercial lives, has been outstanding. The level of support from the state Medicaid director through the plan leadership has been phenomenal. And the Hawaii Department of Education really took the lead here in contracting with Hazel to cover over 170,000 students across 256 plus schools. In 3 weeks right now, we will be launching at home statewide. We will be launching in school at the summer school pilots, and then fully in schools for back to school time. And understanding that this was really a unique collaboration between the Department of Education, the Department of Health and Human Services, or in this case, MedQuest, and just a plethora of support from everyone from the Attorney General to get everything through was just a really, we would love to see more of that, because we see it through school districts, but when you can empower at state levels, we're seeing more and more buy-in. And even those people who are now coming back and saying, how can we be the next Hawaii? Because we see the streamline advantage that this brings. And so that really ensures that every student will have access to care when they need it and where they need it.